All right. Thank you all for coming. My name is RF Noorbash. Please call me RF unless I'm prescribing you medications. I'm a psychiatrist by training, Texan through and through. So I went to UT Austin for undergrad, and UT Houston for medical school, and then UT Southwestern for residency and fellowship. About 7 months ago now, a group of clinicians, therapists, nurse practitioners, and I formed a group called Continuity Mental Health. We do a lot of med management. We do a lot of therapy in a collaborative way. We have case conferencing once a week and a variety of things like that. And so we'd be happy to, if there's any patients that require medication management, we'd be happy to help facilitate that. We try to work very collaboratively with our referring providers. And we'll be talking about continuity of care a little bit today. That can be a little bit of a challenge, but it's something that we really pride ourselves on doing just so we can drive the best outcomes. So that's a little bit about our practice. Our contact information is at the bottom. And my cell phone number will actually be included in the follow-up email. So if there's any cases you want to talk out, or questions or concerns, or a unique circumstance, I'd be happy to discuss. All right. So a little bit about me. I think I kind of jumped the gun there a little bit, but yeah. So UT system grad all the way through. Um, I currently live in Dallas and practice out of my home office in Dallas. But we see patients, our clinicians are spread across the state from the Valley all the way up here to Dallas, San Antonio, Austin, Houston, et cetera. And we see patients all across the state of Texas. My email address is here as well. I didn't put it in the deck because I try to keep. I didn't put my cell phone number in the deck, but it will be included in the follow up email. And I don't have any disclosures really to say to speak of, aside from the fact that. Um, this kind of continuity of care and medical comorbidities in psychiatric practice and mental health generally is something that I'm really passionate about. So, as far as disclosures go, I am a patient that has treatment resistant depression. I also have significant number of medical comorbidities, MS, autoimmune thyroid issues. And so managing all those things and the intersection of those things with my mental health is something that I personally had to figure out how to navigate. And it's something that I think is really important to be able to facilitate our patients navigating as well. So a little bit about our agenda today. We're going to talk through some kind of some of there are a lot of medical comorbidities that come up when we're treating mental health and psychiatric conditions. We'll talk through a few of them today, and kind of how I think about medical comorbidities when I'm assessing a patient. And then we'll spend some time discussing kind of issues with continuity of care, kind of across the medical spectrum, but especially when it comes to mental health and how, as med management providers and therapists, maybe we can interface, in a way that's very productive to facilitate best outcomes for our patients and work together in that regard. I hope today this is a very kind of conversational talk. So if any questions come up, please stop me. Let's talk things out as they come up. That's kind of the way I like to do these kind of talks. It's all about the collaboration. So a little bit about kind of medical comorbidities. So I feel strongly that when I am evaluating a patient for the first time, it is important to kind of have some framework or formulation that I'm working off of to kind of plug information where it needs to go and make sure I'm not missing anything that's contributing to their presentation. So there's probably over 100 different ways of structuring this. I think every clinician kind of has their own way of putting together a formulation. This is the one that I kind of think through the most often. It's the one that I was trained on. For years, we had to fill out this grid for every patient we saw. But what we're going to be focusing on a lot today is kind of the biological constructs and how those interact with both kind of how they predispose our patients to mental health concerns and how these biological issues or medical comorbidities might be affecting the presentation and potentiating kind of illness and getting us, preventing us from getting to where we want to be, which is remission. Yeah, this is the framework that I generally use and actually kind of write through in a lot of my assessments and plans. So as we talk about um, psychiatric disorders in the context of medical comorbidities, I kind of lump these into one of two places. We either have kind of primary psychiatric disorders, which is the majority of what we treat. These are mental health conditions that aren't being directly caused by a medical condition. A medical condition might be exacerbating or potentiating the diagnosis, but there's not a direct causal relationship between a medical comorbidity and what we're actually treating. What you'll often find is that these disorders have like a very bidirectional relationship in the literature with medical comorbidities. So a really good example of this is like major depressive disorder and type 2 diabetes. Major depressive disorder through a variety of mechanisms, most of which aren't really well understood, increases the risk of somebody developing type 2 diabetes. But if you have type 2 diabetes, your risk of developing major depressive disorder is also like greatly elevated. And so there's this kind of interesting bidirectional relationship between the two. Um, the second class of psychiatric disorders, as I think through these things, are kind of, they wouldn't technically be called like, major depressive disorder or depression. They would be called, depression, caused by a general medical condition. So these are disorders that are being directly caused by a medical problem that's either been diagnosed or not yet diagnosed. By somebody in the patient. And so when I'm doing an initial evaluation, I'm both looking for kind of medical comorbidities that might be affecting a primary psychiatric disorder, or I'm looking for medical conditions that aren't well controlled that might actually be causing the symptoms the patient is experiencing. And generally, you'll see, and these aren't hard and fast rules, but you'll see that generally this is more of a unidirectional relationship. So a good example of this is certain kinds of cancers. The presenting symptom of certain kinds of cancers can be depression. At least once in my career, I've had a patient come to me with a really atypical kind of course where he was in his late 60s, had never had an issue with a mood disorder in the past, and suddenly for the last month had really severe depression. And it was just kind of an odd presentation. When you dig a little bit more, patients having a lot of reflux, feeling full much more easily, no pain, but kind of this new onset, more chronic GI issue. And he ultimately was diagnosed with a pancreatic cancer. And so it's important to be able to kind of dig in and for me as a physician, make sure I'm not missing something, do the best that I can to make sure we're not missing an actual cause, because the symptoms won't generally get better, the symptoms of their psychiatric condition that they're presenting with, unless you actually evaluate and diagnose and treat that medical condition. Any questions so far? So let's talk through kind of the primary. So this is the stuff that we kind of our bread and butter, what we see most of day to day. So what's important to realize when we're treating patients with any primary psychiatric disorder is that they are at a much higher risk of developing or having many other medical comorbidities. So just generally speaking, for example, with major depressive disorder, which is I think where this is best studied, there are a lot of at least 33 or 34 now medical conditions that we know are at much higher diagnosed at much higher rates in patients with MDD. And a lot of those conditions may be present and have yet to be diagnosed. And so having kind of a high threshold of suspicion for other medical issues, making sure that you're asking kind of all the things about their physical health, et cetera, is something that's important to me when I'm doing an initial workup. These patients, on average, are also conversely much less likely to be receiving adequate medical care. So we know that patients, for a variety of reasons, kind of the symptom burden is one kind of part of this. Another part of this is that there can be kind of bias within the medical system and with medical providers. So really, really good example of this is schizophrenia. So patients with schizophrenia are well understood to receive substandard kind of long-term medical care, especially when it relates to dealing with cardiovascular risk factors and managing those. And so the kind of the most common non-psychiatric cause of morbidity, mortality, and schizophrenia is actually cardiovascular disease. And we do a pretty poor job as a medical community of making sure those patients are well integrated with care. And it can be difficult because of their symptom burden as well. And then the third point here is that it's really important to realize that the outcomes of both the psychiatric disorder and the medical comorbidity are linked. So if you have somebody who has, major depressive disorder, recurrent, currently moderate, as well as type 2 diabetes that's not well controlled. Um, you need to tackle both. So it is very unlikely to get to remission of their MDD if their type 2 diabetes isn't better controlled, and their nutritional status isn't improved. And conversely, it's much harder to get their type 2 diabetes under control when they have significant symptom burden from their depression. And so, making sure they're in comprehensive care, making sure both are getting treated aggressively is really important for overall kind of prognosis for both conditions. So some examples of this, and these are all disorders in which depression makes them more likely, and that their being present makes depression more likely. So some examples in MDD. We talked a little bit about type 2 diabetes, but that also includes kind of metabolic syndrome kind of as a whole. So things like poor nutritional status, um, high cholesterol, hypertension, kind of that trifecta of metabolic syndrome, insulin resistance, if it's not frank type 2 diabetes, these things can all contribute. And so that's something to kind of be on the lookout for. Cardiovascular disease is kind of the second most well researched for depression. So it's really, and this is a little bit more complicated of an interaction, but just having high blood pressure puts you at a much higher risk of developing depression. The lifetime prevalence is way higher, even if it's well treated. And so same goes with atherosclerotic disease, coronary artery disease, and a variety of other cardiovascular issues. Autoimmune conditions. This is actually a really strong association. And we're going to talk a lot today about the role of inflammation in driving psychiatric conditions, especially with respect to mood disorders like depression. So inflammation is designed, like by evolution, to put you on the couch. To prevent you from engaging in physical activity where you're going to overexert yourself. And the example that I use with patients with this is the flu shot. So the flu shot, it's inactivated dead flu virus. If it's pieces of virus, it can't give you the flu. But a lot of people feel like they get flu symptoms when they get the flu shot, and all they're experiencing is the really powerful ramifications of a inflammatory response in the body. So that's all those behavioral changes of not wanting to do anything, sleeping a lot, potentially not eating as much, those kind of things are all being driven by chemicals, cytokines, we call them, that are getting released because the body's getting ready to fight something. And those same symptom domains overlap a lot with depression. And so autoimmune and inflammatory conditions are a really, really big component to this. Infections. are very common. Again, another inflammatory condition. And so, for a lot of patients, one of the most common kind of subclinical infections that I find in my practice that might be exacerbating depression, especially in the elderly, are urinary tract infections. So it's quite common for me. I don't want to say common, but it's not uncommon for me to get a patient. An older patient who is kind of just acting odd. Has there been a sudden acute change? They are presenting as depressed or anxious or a little confused, and you go and do a urinalysis, and they have a UTI that needs to be treated, and generally clears up. The symptoms clear up thereafter. And then neurodegenerative diseases and dementias. These are another kind of common thing that I think about for a very large percentage of patients with like Parkinson's disease, for example. Their first presenting symptoms are mood and personality changes. They don't generally present with the movement issues first, although that's the stuff that usually gets them into the doctor's office finally. But looking back in retrospect, you can identify a lot of mood and personality and behavioral changes that might have kind of been early warning signs. One of the most common ones actually is kind of acting out sleep behaviors with Parkinson's disease specifically. So that's something that I kind of ask about, especially in older patients, to try to kind of better understand what I'm working with. And then the last, but certainly the last on this list, but there's a ton here, is chronic pain. So the intersection between pain and psychiatric disorders is complex. It is something really important to think about. Pain actually, depression actually kind of biologically lowers the pain threshold as a mechanism to protect the body. It makes you hypersensitive to threat. People with chronic pain conditions generally have worse pain when their depression is decompensated, and vice versa. Chronic pain through a lot of complicated mechanisms can really exacerbate mood disorders, especially depression. And so tackling both of these at the same time is really, really important in terms of outcomes. Any questions about kind of primary psychiatric disorders? Okay. And
Just
then
want to
second,
say that's
yeah, please.
so
Yeah,
useful, I think, in particular to our clinicians and our
yeah.
practice. We work really relationally, and a lot of the time we're sort of looking at symptoms through maybe more of a somatic lens. And as you were going through that list, I was just thinking about so many clients that it's like we really do need a second set of eyes on these symptoms so that things don't get overlooked that are a primary origin and something to be explored. So anyway, all of that to say, very useful reminder there.
Yeah, and I think a really important reason as to why collaborative care is kind of the best kind of care. So working together as a team, kind of with our own strengths to try to make sure we understand all the different factors that are going into a particular presentation. Yeah, I agree 100%. So secondary psychiatric disorders, these are disorders that are being caused by a primary medical condition. And so as the DSM calls it, a general medical condition, whatever that means. And so this gets a little bit detailed. So I'm not going to go into all these details, but um, uh, the important take-home message here is that unless you identify and manage the cause, generally the psychiatric condition is not going to get that much better. Whenever I have a patient who comes to me with like treatment-resistant mental health concerns, like especially treatment-resistant depression, kind of this list is something that I go through in my head, and a medical workup is something that I do to make sure we're not missing something. There are initial labs. I don't order labs on everybody who walks in the door with depression, but if it's an atypical presentation, if it's treatment resistant, if there's something that's kind of like setting off the spider sense of this is not quite your typical case, then I do order pretty extensive lab work to check for a variety of things. And so that list is on the right, and this is more so geared towards depression, because that's where this is best understood. But for other conditions, there are other things that I might check as well. But the ones that I want to rule out are thyroid issues. Both hypo and hyper thyroidism can cause mood disturbance. Blood count abnormalities can give us a whole variety of information on is there an infectious cause? Is there anemia present? Is it iron deficiency versus something else? At least once I've had a patient with treatment-resistant depression come in and nobody had ever done labs. She hadn't seen a PCP in a very long time. She actually ended up having a kind of a rare chronic blood cancer that was impacting her case. Electrolyte abnormalities can sometimes lead you to diagnoses like Cushing's disease, or other issues with like cortisol or steroid hormone function, liver and kidney issues, vitamin issues. Hormonal changes and perimenopause is something that we talk about a lot, and I do check those levels in the appropriately aged patient. Infection, substance use, pregnancy. These are all things that I've also had at least one case where presenting with a lot of fatigue and changes to behavior, and thought they were depressed and they were actually pregnant. So the pregnancy test is something that I check for if they haven't already. But if you're, so as a therapist, if you're looking to see if your patient, you're like reviewing lab records or reviewing records from an outside clinician and just want to see if your patient got a kind of a thorough evaluation. These lab results on the left are the things that I'd be looking for, especially the ones in bold. Those are kind of your go-tos. So you want a CBC, a complete blood count, a CMP, a comprehensive metabolic panel. You want thyroid levels checked. You want a B12 and folate level, and you want a urinalysis. Sometimes they'll order a drug screen in certain cases. I don't like doing that because it kind of can be a disruption to the relationship and the trust you're trying to build, especially early on. But substance use is a leading cause of psychiatric conditions, so it's important to rule out. And then in men, I check testosterone levels, especially if they're a little older. Although young men sometimes present with hypogonadism and low testosterone, and then FSH or LH for women to kind of rule out perimenopause being a contributor to symptoms. And then very rarely, I've never had anybody with tertiary syphilis, but syphilis it's on the rise. Especially in the geriatric population, and it can when it does infect the brain, it can present with mood symptoms initially and psychiatric concerns and odd behavior. So it's something to kind of keep an eye out for. Very rarely will I order any imaging. Usually, if I'm thinking imaging is necessary, I'm either sending them to the ER because it's something emergent, or I'm referring them to neurology for a full neuro workup. But there are a huge number of things that can present, I guess, is the take-home message. And if there's anything that's off about a case, or there's a lot of treatment resistance, or we're not making progress, making sure that the patients had a thorough evaluation for all these things is really important. Um, yeah, I know this is a little bit kind of in the weeds, so to speak, but any kind of questions or concerns or thoughts about this?
I think especially in the eating disorder realm, the
Yeah.
B12 and folate seems like that is a very good indicator for us that someone is in the right hands.
Yeah. Yeah, yeah. Especially in eating disorders. So I did a child and adolescent psychiatry fellowship here in Dallas. I don't see anything but adults nowadays, but I remember at our inpatient unit in Plano, which it's a pretty big inpatient eating disorders unit. Nutritional status and where they are with like, is the brain fed? can the brain participate in like therapeutic interventions at the moment, is really important. And there's a lot of, and I'm kind of speaking to the choir here, but I think it's often misunderstood by the public that people with eating disorders, what the cause of death might be, or morbidity. And very often that's kind of the medical complications of, most often it's the medical complications of their eating disorder. And so yeah, especially in those patients, working with a physician who's like on top of all that stuff is really, really important. Both to make sure that they're, progressing from a nutritional status, and just to make sure that they're safe. That's really important. Yeah. Oh, no, no problem. And then let's see here. Um, yeah. Any other questions about secondary psychiatric disorders? Yeah, I think this is very, very important in the eating disorder space, for sure. And then there's this whole other kind of class that I think about. So, drug-induced secondary psychiatric disorders. So, iatrogenic psychiatric, symptoms being caused by medicine. This is actually really common. Um, so the most common offenders I see in my office are beta blockers. A lot of people, it's like it's on TikTok now, like getting propanolol for your performance anxiety or other things. And it really, beta blockers for a lot of patients can induce symptoms of depression, fatigue, anhedonia, concentration difficulties, a variety of things. Opiates can cause depression through various mechanisms. And then there's two other big ones that I see a lot. One of them is a medication called Singulair or Montelukast. A lot of people are on Singulair, especially in the Austin area because of the allergies. And it has a black box warning for neuropsychiatric side effects, and the rate is like 20%. It is not a small number. And so whenever I have patients who are on Singulair, I kind of ask temporally, how are your symptoms related to when you started this med, and do you think it got worse after you started it? And working with their allergist or pulmonologist, whoever it is, PCP, to try to find an alternative to get them off of it, just to see if that will improve. The other big one's melatonin. So melatonin, I'm kind of like, this is like a little point of interest for me, because melatonin, we're one of the few countries where melatonin is not a prescription drug. It's available over the counter here for reasons I still don't quite understand. It is a hormone. It's a hormone like any other hormone your body makes. And the doses that are available are really high. So a 10 milligram dose of melatonin, which is the common dose that I see in the office, gets you blood levels of melatonin that are about 10,000 times normal. So there's a normal peak around sundown during the day, and you don't want to overshoot that level by a whole lot, especially chronically. So what starts to happen is melatonin receptors get desensitized, the circadian rhythm gets disrupted, sleep-wake cycles get disrupted, as well as sleep architecture. And then high dose melatonin chronically can actually suppress hormone production. So it can cause hypothyroidism, it can cause low testosterone, it can cause menstrual suppression. I had a patient who came to see me. He had been taking horrible depression, horrible sleep, had been taking 20 milligrams of melatonin every night for 6 months. Had been recently diagnosed with hypothyroidism and low testosterone, started on supplementation for each. No better than he was before in terms of his depression. And it was all caused by the melatonin. When we stopped it, he was able to get off of everything and felt much better. And did a little bit of psychotherapy and some other things to deal with some kind of psychological potentiators for his depression that kind of started the whole cycle to begin with, like post-divorce. But melatonin, yeah, is a really, really big one. Um, And then the last big one is substance use. Alcohol is a big one, and there's a few others. There's a few other diseases I kind of just listed out here to the right, to be on the lookout for. But the big one that I think everybody should be thinking a little bit about is sleep apnea. Really common, and something that can really exacerbate mood symptoms and cause mood symptoms if not adequately treated. All right. Okay. So last but not least, continuity of care. Um, why do we care about continuity of care? There's a reason I named my company Continuity Mental Health. This is I think the most important part of provisioning healthcare in kind of a system that's as complicated as we have. We got to work together to drive best outcomes. Patients trust us more when we do. The care that they're getting is more personalized to their specific needs. The outcomes are better. The adherence to treatment is much improved. We have reduced need for higher levels of care. It actually saves money by keeping people out of the hospital, keeping people out of the ERs when we all work together to facilitate this. But we don't do it very much. And there's some really good reasons why. There's a lot of barriers to us all kind of working together, especially if we're not in the same practice. So we might be in different practices, different locations, probably different cities nowadays with telehealth. Being able to kind of engage can be really difficult from just a logistical standpoint. You would hope that like now that everybody has to use an EMR, basically, that would have made the situation better. But EMRs are not kind of there's not an easy way in EMRs to share information and to communicate and collaborate. So like just sharing notes is not the same as having a conversation about what's going on with a particular patient, how we're going to tackle it together as a team. And then there's legal considerations too. And I think this is especially important when we are talking about therapy, because therapy is protected under HIPAA differently, especially psychotherapy notes, compared to just like a normal medical record. And so, how we facilitate that? Do we need to get an ROI signed for each provider so everybody's got one on file? I mean, the logistics from a legal standpoint can get pretty complicated. But I think the biggest one is really time constraints. Madison, you and I having a 30-minute conversation about a patient, not reimbursable. Can't bill insurance for it. Usually can't bill the patient for it. Not sure that we would want to. It being, I've always found this like just to be curious. Like if my lawyer makes calls for me on my behalf and collaborates with other people, that guy's charging me per 15-minute block. But in medicine, we can't do that for a variety of reasons, especially when you're like we do at Continuity Mental Health, when you have an in-network model and you're, primarily billing insurance. So being able to support the practice and support yourself and provide the best care is really difficult in that context. And then, do you have time? Are you bogged down with like your own scheduling and notes and all the other things that, administrative overhead that we need to do, and how much support do we have to get those things done to free up time to do these things? That can be really, really difficult. Having support for all those other administrative things and trying to make them kind of less a part of our day and make the important stuff more a part of our day is like the constant struggle, right? So there's that. And then the last, and I think this one is actually one that's not talked about like nearly enough, is role ambiguity. So what's everybody like responsible for? What are we like supposed to do when we have a conversation, like we identify these things, and how do we tackle these as a team? And so whenever I have a conversation with another clinician, whether that's like another medical provider they have or a therapy provider or whoever it might be, I try to kind of end the conversation with like pretty clearly defined like roles and responsibilities of how we're going to tackle this. So kind of take homes that we can actually kind of actualize and execute within the context of whatever we're doing with the patient directly, so that we can kind of drive the outcome that we want. Um, but I kind of outlined specifically with therapy, some areas that I think are really synergistic that we should try to focus on a little bit more. Um, and these are things that are important for outcomes. And so the biggest by far is adherence. Patients see therapists way more often than most other clinicians, just by virtue of kind of the logistics of psychotherapy. And so making sure that patients stick into treatment plans, going to appointments, is following up with their medical doctors, their psychiatrists, and all the other people they need to follow up with, or would be ideal for them to follow up with, is really hard for them to do, especially when they're struggling, and something that we can kind of help them with. I have patients that need like three or four different specialist workups. Like they need to see a cardiologist, they need to see an endocrinologist, they need to see an OB, that kind of thing. And kind of so we'll kind of set like SMART goals. I do a lot of little CBT-ish stuff in my practice, and so we'll set a SMART goal before the next visit of like scheduling one appointment. Or identifying, finding a provider or something like that. The other parts of adherence, though, are with medications. Average adherence to medications is somewhere between 60 and 70%, depending on the study you look at. So helping patients with medication adherence is really important in terms of if medications are going to be efficacious or not. Long-term engagement with care, so having a patient not just kind of disappear after a couple of months of treatment, but stay in treatment in a longer term so that the overall outcome and risk of relapse is lower, is important. And then also just like from a safety standpoint, are they sticking to like a safety plan if we have one? Are the meds locked up? Is their spouse or whoever else engaged? To help keep them safe, those kind of things. I think that's a really important piece of how we can collaborate together. Um, uh, Side effects are big. So about 70% of patients on a psychiatric med will experience a side effect. And for a lot of those patients, they won't tell their provider, they'll stop it. And so this is especially true with sexual side effects. So if I put somebody on an SSRI like Zoloft, about a third of them will have some kind of sexual side effects. And it's something that they might, side effects generally, but especially those that are a little bit more difficult to talk about, or something that might come up in the context of a therapeutic interaction versus, them seeing me for a 30-minute follow-up for med management, once a month or whatnot. And so identifying those, encouraging them to talk to their psychiatrist, reaching out to their psychiatrist and letting the psychiatrist know the patient's having a side effect, that's really important. There's a variety of behavioral interventions that I think are really important in terms of treating psychiatric conditions. But for me, I do a lot of mood disorders work, and physical activity is always the difficult one. Depressed people don't want to work out. But the evidence suggests that 150 minutes of moderate intensity exercise a week is as good as Prozac. And so that's a really important piece. Um, Helping identify the non-medical stuff that we need to work on. So the psychosocial factors, the maladaptive behavioral patterns. We all have different perspectives because we're interacting with the patient in a different way. And so identifying those can be really helpful. And then also catching decompensations early. I kind of tell patients, let me know if things aren't going smoothly. It's easier to put out the fire if it's still just smoke and it hasn't really, flared up, right? We don't have to dump as much water on it. And so multiple providers working together to identify that early is really, really important, especially when we talk about safety and cost effectiveness and keeping people out of the hospital, because that's never a pleasant experience for anybody. Psychoeducation, expectation setting, helping patients understand kind of that their disorder is likely multifactorial. Medications can be somewhat helpful, but generally aren't curative. There's a lot of psychological and behavioral factors involved that we need to work on, so that these things are less likely moving forward. Just helping them understand themselves better is something that we can all participate in. And then yeah, we talked a little bit about safety, but it's ensuring safety of patients because that's kind of number one, on my list of things. Um, Thoughts about areas of synergy or other areas that we could all kind of work on together as like med management and therapy providers.
Oh, I think everything you're saying really aligns with my thoughts about this stuff as well.
Yeah.
I did have a question that might be
Yeah,
a little bit unrelated. I
please.
was wondering if you ever encountered long COVID and how that intersects with interacts with mental health, because I've had some clients with long COVID symptoms
Yeah.
and they've definitely been struggling with the effects of that on their mental health as well.
Yeah. So long COVID is, and let me preface this by saying that long COVID is definitely a phenomena. I think that there's like some ambiguity about this for some reason. But it is definitely now well understood that people who have COVID, especially severe COVID, have very long-term sequela of their infection. And it's like not even clear if the infection was totally cleared. So in some of these patients, you can go and actually find active viral replication, like in the GI tract and other places where there's reservoirs of virus that have never really been eradicated. So what causes long COVID, we're not quite sure. That's like obviously an area of very active research. But in those patients, you can measure elevated levels of pro-inflammatory compounds. And so there's like a hypothesis one, there's several, but kind of the two big ones are that there's inadequate clearance of the virus and the virus is kind of hiding out someplace and kind of stimulating this long-term inflammatory response to keep it suppressed. So it never quite goes away, and you're just kind of holding it at bay, and it's not causing the same kind of systemic symptoms as it would, like if it was in the lungs or somewhere else, right? And then the other thought, and you see this with other post-viral syndromes, like with the flu or other things, where somebody has an inflammatory response to a potential or a particular pathogen. And then that inflammatory response kind of goes a little bit sideways. And once the pathogen is gone, the response doesn't really stop. It kind of stays elevated. So it's like an immune dysregulation after an infection. And it's probably likely that depending on the patient, I think there's probably a lot of reasons why people have long COVID, and it's going to vary. Um, but those patients, I think, are best served by going to a provider that is specializes in long COVID. And so an allergist, immunologist, they kind of do the same training. So allergy immunology. There's immunologists that are specialized in helping treat long COVID nowadays and do assessments. And there's certain things that have been shown to be helpful. But I lump it into the same category as kind of like other pro-inflammatory conditions. Kind of going back to the flu shot analogy, where it's like that never stops for these patients, and they're really suffering. And so there's certain medications we might use from a psychiatric standpoint, like Wellbutrin, for example, has been shown to be more helpful in patients who have a high inflammatory burden than other antidepressant agents. And there's other things that we might try and do a little bit differently in those patients. But it's a tough problem for people who are struggling with long COVID. It's a great question.
Oh,
Yeah.
thank you. I think that the impact of the inflammation is so applicable to so many clients that I've seen. So I appreciate that insight there.
Yeah, yeah. And there are sticking to like I know that I've had patients with long COVID who've tried like an anti-inflammatory diet where they eliminate saturated fats. They stick to a more Mediterranean kind of diet with a lot of polyunsaturated fats, and do things like that, where that can be helpful in kind of tilting the dysregulation of the inflammation into something that's a little bit less disruptive. Yeah.
Yeah, thank you.
Yeah, no problem. Any other questions? Anything else that comes to mind during our discussion today?
Not at the moment, but this has been such a great presentation. I really feel like I learned a lot and I appreciate your time here.
Yeah, thank you very much, Madison. Very nice to meet you.
You as well. Thank you guys.
Yep, have a good day. Bye bye.